Rajendra Prasad, who is coming from JNU, University, and he will be speaking on, I think, very important issue, the drug resistance, how the drug resistance should be improved in our healthcare issues. Please, Dr.
Thank you very much. I'd like to thank the organizers for inviting me. Frankly, I did not come here before, but I'm very impressed. And impressed also with this very appropriately timed conference. And I've seen the program, although I'll be gone, but I hope we'll have a good time for the next 2 days. I selected this topic because first of all I work on it, and second I thought this will also make you aware of the problems which we gist each day and we face each day. It's a really nightmare for clinicians. That means multi-drug resistance, and I try to say from microbes to man, because many things which happens in microbes also happens in man to become resistant to drugs. And for the sake of students, when I say multi-drug resistance, it means a resistance of an organism against a spectrum of drugs that neither share a common target nor a common structure. Apparently very unspecific. A organism can become resistant to variety of drugs. They may have nothing in common, not structurally, not target-wise. So it becomes very, very difficult. Once a organism is resistant, it becomes resistant to many, many compounds. I take it back long time ago, around penicillin time. Penicillin was discovered in 40s, and this particular poster is thanking penicillin because the World War, the soldiers could be saved from common infections because of penicillin discovery. And in fact, it was termed those days as a miracle drug because it could cure most of the infections. And in fact, it was thought that we may not require very many drugs to cure infection because this was good enough. So that's why it was a miracle drug. And you know, I mean, as of mentioned, miracles don't last for very long, and that's what precisely happened. That effectiveness of penicillin was started fading right within few years of its discovery. If you just see a time scale of antibiotic discovery, here is penicillin, which was mass produced in 42, and already in 43, we could start getting organisms resistant to penicillin. And that is true for most of the antibiotics. And tetracycline was in the market in 52, and 54 we had bacteria which were resistant to tetracycline. And this happens over the time. It took shorter time to become resistant than it used to take, say, in the beginning. So bacteria were getting smarter each time when you throw any compound to them. In the meantime, when we had all these drugs based on penicillin and other related chemical structures, almost 40 years, because we thought that the drugs of penicillin kind are enough to cure all the infections, drug company never put any money to invent new drugs. There was a gap sort of in the getting new drug in the market. And that really took us by surprise that on one hand, the bacteria started getting resistant to the existing compounds, and on the other hand, there were no new drug coming in the market. Till in 80s, when they realized that this is a very serious problem, of course now they are trying to make new drugs with new target so that bacteria do not learn the tricks to handle or destroy the drug as it comes. What really took everybody surprise was that first we thought that when, say, penicillin was discovered, that genetically speaking, a bacteria acquiring mutation to become resistant, the frequency of that happening is very, very low. But what we did not realize that time was that there is a horizontal transfer of information. If you see this cartoon, you have two populations, a drug resistant and a sensitive. Now there is a horizontal gene transfer. The resistant gene can conveniently be transferred to otherwise sensitive cells, irrespective of what bacteria it is or what species it is. So if that happens, then the whole population gradually becomes resistant. And this is much quicker than you think of becoming that bacteria will become resistant to drug by acquiring mutations. So the horizontal transfer of gene was a sort of a surprise, and this describes nicely in a cartoon that you just put a gene resistant trait to another bacteria, and that makes it also resistant organ. Another problem which led to the emergence of resistance was that excessive use of antibiotics. In our context, you know that you can buy antibiotics from any chemist shop, and everybody is a doctor. That I can treat you, you can treat me. So that misuse of the drugs is also leading to this problem, or sort of compounding the problem. So once it is a very judiciously if you use, this can also be sort of one aspect which can minimize the emergence. So overall, we are having till today situation like superbugs. If you remember some months ago, I think last year, there was a bacteria discovered in New Delhi, bacteria which was supposed to be resistant to all the antibiotics. But there was a big discussion. So these superbugs are the result of acquiring resistance to the drugs, whatever drugs are being thrown out. Invariably, how antibiotics which we have work. Some works on cell wall synthesis blocking, some work by blocking protein synthesis, some works by DNA conformation, some affects protein synthesis. So these are known targets which are being targeted of a bacterial metabolism by known antibiotics. On the other hand, bacteria have also learned how to fight back these antibiotics. For example, very common is that you have some enzymes which can destroy the drug. So for example, this happens in E. coli. Then you have some bacteria which can modify the target. So drug cannot bind anymore. Okay. The most interesting part, which is I'm going to talk more about it, is that as the drug gets in, it is thrown out of the cells. Okay. So the concentration of the drug, which is otherwise effective, is not allowed to be built inside the cell. So they keep throwing drugs out of the cell. So on the combination or either of one of them are responsible for this organism to become resistant to cells, to drugs. And I'm trying to tell you now slowly is that this mechanism that the drug can be thrown out of the cell is common from humans to microbes. This is a well-known fact that MDR in cancer is a nightmare, and almost close to 50% cancers do not respond to chemotherapy in due course of time. Why? Precisely that these cancer cells also acquire resistance to drugs. Precisely same way as bacteria does. Okay? So there is a commonality between the two processes. And this is not sort of true only for bacterial infections or cancer. Many places, fungal infections I will talk to you in a while, HIV, malaria, leishmania, amoebiasis, all the causative organisms respond to and eventually become resistant to drugs. So it is not restricted to one kind of disease. And over the period, many organisms have adopted many strategies to become resistant. For example, some can sort of try to avoid the entry of the drug into the cell. Some can increase repair mechanism, so the damage can be repaired. Some improve, activates the drug. Some can block apoptosis, the cell will never die. And of course, some are doing the over-influx proteins. So these proteins are overproduced in cancer cells and resistant cells. So then more of the drug is thrown out. So there is a common theme behind the resistant organism. For example, the flux protein catalyzed extrusion of toxic compounds from the cell is one of the most frequently used for studies for resistance. So as the the drug gets in, it is being sucked out by these efflux proteins. Okay, so that's the strategy. So if you have these proteins overproduce all over the membrane, then obviously the efflux is much more faster. So toxic drug will not be inside the cell, and as a result, cell will not respond to the drug concentration, and that is what happens in cancer cells. So we have these efflux pumps like bouncers. Bouncers probably you know. These big guys who sit on the front of the restaurant and pull around the wrong people to get in. So these are the several bouncers who allow these toxins not to build up inside the cell. Okay? And if you look at this, what kind of these transporters are? Among many types, cell have got two superfamily of transporters. One is called ABC, because of ATP binding acid it has. It is superfamily of the transporters. The other is major facilitators, which are also there. So both work to throw the drugs out. There are two set of proteins. Either as the drug gets in, it is sucked out like a vacuum pump. This is one possibility. The second is that drug gets in and from the one monolayer it is flipped out of the cell. So the whole idea is to not allow drug to go into the cell. It is handled at the membrane level. Okay. Now I'd like to tell you briefly that this particular phenomenon of resistance is not restricted, like I said, to many diseases. Also, it is quite common in fungi. Okay, not only one fungi, but several kinds of fungi. And that is also my area of interest. And fungi, when we talk, we always think of good fungi. Okay, which gives you wine, cheese, and bread and everything. But then we have a host of bad fungi, which causes serious infections to our cells and also spoil our food and have very different kind of morphological shapes to exist in body, and you can see they can go deep into body tissues and survive. Okay, and if you look, some common fungal species like causes aspergillosis, cryptococcosis, mucormycosis, candidiasis, all these diseases you find the causative organism like aspergillus, cryptococcus, candida become resistant to fungal drugs. We don't call them antibiotics, we call them antifungals. I give you this example of this one yeast which we work on, Candida albicans. Okay, it is a pathogenic yeast, but normally it is a harmless commensal. It has, with all of us, with our system, it only affects us and infect us when we are immunocompromised. And when you are immunocompromised, HIV patients, people going through immunotherapy, heart transplant surgery, and so on and so forth. That time, this is one of the most common infection in this patient. I mean, it is one of the most common secondary infection with HIV patients. Okay, and this is very interesting. Another look at the MFS family of proteins. There are 95 MFS proteins. Okay, however, out of 28 proteins, only 2 that is from ABC and 1 from MFS are drug transporters, are involved, clinically speaking, in antifungal resistance. So most of the proteins, what they do, we don't know at this point. Interesting thing is, these proteins, be it in Candida, be it in Patigi saccharomyces, be it in humans, this is the cancer protein, or in bacteria like E. coli. And if you see the blue color, trying to say that they are very conserved proteins, very similar homologs. Okay, so there is a commonality between these set of proteins from microbes to man, that a unifying mechanism exists, thereby cells become resistant to drugs. So we spend a lot of time on the structure and function of these pumps, and also, of course, how the genes which are not produced are regulated. So briefly now I'll try to tell you some of the results and try to avoid the technical details so that it's clear. The whole basis of our work is that as the drugs are thrown out, so we want to interfere at cell surface level and try to block these pumps. Okay? If you block the pumps, the drug will not go out. So same drug can be reused, because the drug otherwise, if it stays inside, is able to kill the cells. Or if you can handle the regulatory aspect of these genes and try to block the expression of these genes, again these pumps cannot be produced, so the cells will not be replaced. So based on these two approaches, this will involve a lot of structure function studies, this involves a lot of regulation studies. We sort of concentrate our efforts for many years now. So to achieve this goal, I try to tell you now some information. And these are the two proteins I told you, efflux pumps, which are major proteins involved in drug resistance, in Candida now particularly, in Candida albicans. On one hand, CDR1, which is ABC protein, is a major drug efflux pump. And like I said, the ATP powers the drug efflux. And if you look at the cartoon of this protein, which is very important, it has got two areas, what we call NBD, nucleotide binding domains, where ATP binds. Okay? And then these are the transmembrane domains. That means there are 2, 1 and 2, 6 times 6 helices each. So 12 transmembrane segments makes 2 transmembrane domains, which precedes 2 NBDs, one here, one here. So it looks like a gene duplication. It looks like half of this protein has been doubled. Okay? And obviously you can overexpress these proteins in systems, and you see, you can tag them with fluorescence, and you can see how nicely they overexpress in your experimental system. The other set of protein is MFS protein. Like I said, it is not a ABC type, it is a major facilitator. It pumps drugs out at the cost of proton, and so that it is not a antiproton motif and so on and so forth. So these two are the major efflux pumps which are overproduced in azole-resistant clinical isolates. Another feature of these pump proteins are, whether it is MDR or ABC type, they can efflux variety of compounds, azoles, aromatic imidazoles, triazoles, steroids, anti-cancer drugs. So like I said in the beginning, this MDR means structurally unrelated drugs. All can be substrate of these pumps. So there is a paradox that your own drug can become a substrate of these pumps, so it will not work. Okay, and this is true for typical for this kind of proteins, that they can efflux not one, quite a few kind of compounds. And if you compare the two set of proteins, for example, this is ABC, this is MFS. A lot of pump substrates are very, very different for each protein, but there are quite a few are common also, substrates. Okay, so there is a lot of unspecificity about these proteins. At the same time, they are also quite specific. Okay, but we are not able to still work out, structurally speaking, if you're looking at these chemical structures, that what is minimum required for a compound to become a substrate and what is required for a compound not to be a substrate. And once that you know, you can also make a synthesized inhibitor which will not be a substrate and can kind of block the bonds. Now I'd like to tell you some little more detail of this aspect. Go back to that cartoon, look at that NBT where ATP binds, and look into it. It has got several subdomains. Okay, we call them Walker A, signature, Walker B, and so on and so forth. Never mind. If you do a sequence analysis of those motifs, you will find that almost identical throughout the evolutionary scale. If you see this, this is a human protein, PGP, and so on and so forth. Everywhere, these motifs are identical. I keep telling you that these are very homologous, conserved superfamily of proteins. Now, look at the bottom, that the ABC of Candida, for example, is slightly different from the rest. Okay? Here, the K short form means lysine, C means cysteine. So in short, I am trying to tell you, a lysine which is present everywhere is replaced by cysteine in Candida, and that is true not only for Candida but for all fungi. Okay? Likewise, there are some more changes. There is a tryptophan appears here, otherwise it is something else everywhere. If you see more closely, compare with many more sequences, you will find the same pattern. Cysteine is present in all fungi compared to lysine everywhere. So the question comes, why it is happening? What is the significance of this variation? Now I told you this is the variation happening only in fungi, nowhere else. Okay? So there has to be some reason for this. We have been analyzing this for some years, and I won't tell you a lot of data, but just to tell you how we do it. If you look at that cartoon again, this whole protein, we kind of subcoat and purify these proteins to find out how they function. For example, we looked for the role of that cysteine, which was typical, okay, in that range of transporters, not present anywhere else. And we found that there are, of course, 4 more cysteines in that domain. So then we had to mutate all those to find out. In short, I want to tell you that cysteine, which is unique, was very critical for ATP hydrolysis. Okay? And not for ATP binding. So what I mean to say, the replacement is very specific and not by chance. It has acquired a role and by replacing otherwise very conserved lysine. Same way, if you look at these substitutions, which are again very typical, we looked around and we found that a tryptophan, which is very common in fungi and uncommon everywhere, is also very critical for ATP binding and not for hydrolysis. Never mind, we could work out the role of each variant residues of fungal transporters. Okay, to the extent we could also work out the exact mechanistic details, how they function in view of this changed binding pocket nature. For example, we could exactly show how these invariant residues typical of fungal transporter participate in catalysis. Okay, and in 3D structures, we could show that how they are placed and face this particular ATP molecule and catalyze ATP in a different fashion compared to normal other transporters. Okay, and since I told you this, that there is a degeneracy in one of the domains of CDR1, but the other domain is as conserved as anywhere else, including humans. So these two domains, what we call a canonical site and a non-canonical site, work in coherence. Both are important, but like I said, are very different in terms of mechanistic details compared to other fungal transporters. Now I take you back again to that property, which is that they can influx many transport substrates. How it happens? If you look at the cartoon again, I was telling you these domains are very conserved, almost identical. On the other hand, these stretches where drugs supposed to bind are very variable, most variable. And if you look at from the database aligned sequences, you find they are quite variable structures. Okay, so our interest is how drug binds and how it is powered by ATP, so it is thrown out. So you have to find out how drug binds, then only you can make some inhibitors for that to limit the binding. Okay, so what we did here, we mutated all these residues. So 252, 255 type of thing. Okay, the mutation means we replace a residue by allele. Okay, and then try to see what happens to cell function. Okay, in summary, I can tell you, we found that most of the residues do not do anything, but there are quite a few which are very critical in terms of drug binding, in terms of drug efflux, and so on and so forth. This just tells you how you can fingerprint each mutation versus each helix, and we can even place these residues. Ultimately, you want to see how it will affect the whole protein molecule, where they are localized. So we have these 3D models of this protein, and we visualize these are the pink or purple residues which align the binding pocket. Okay, and these are the ones, if you mutate, makes cell sensitive. So drug somehow gets into this trap and interact with these residues to get bound. So we almost know now by now what is the nature of drug binding. However, we still don't know each residue, but at least some idea we have. And this part we already started exploiting to design some molecules which could block these pumps like this. If you block the pump, the drug will not go out and cell will become sensitive. We have two set of molecules. One is modulators Moderators means they will compete the drug efflux. Okay? And when they compete, they will not allow drug to go out. On the other hand, we make some peptide mimics against these helices. Our idea is these mimics can bind to these proteins, mimics with almost identical sequences. So they will block the protein function. Again, block the efflux. I show you some results, very interesting. So these 12 transmembrane domains, we made these peptides, but against each, okay, and shown that they bind and so on and so forth. I just want to show you the result. One of the, if you see the host cells and put a fluorescent drug, you see in a host which doesn't have a pump protein, the drug is trapped inside. But if you have a pump protein, the drug is thrown out and cell is not fluorescing anymore. However, if you put a peptide which blocks the pump, you see, if you put peptide, nothing happens. But now if you put the pump peptide, in spite of the pump, the peptide blocks the efflux, and compare this to this, there is total block of efflux. So you can create these peptide mimics which specifically blocks these drug export. Okay? And these are also very specific molecules, because if you look at this another transporter, MFS, here nothing happens. So you can specifically block the Candida cells, where, for example, if you have a pump, it is thrown out, but if you have a mimic, the drug is trapped inside. Okay, so these molecules then can be exploited actually because peptides are very difficult molecules to handle, but one can optimize them to really become a potential therapeutic agents. In another story, then we have these modulators from the ABC transporters. There are some molecules are known. We also found that one of the very famous natural compound curcumin, which we know all that is very famous Indian spice, it can block the flux of drugs mediated by ABC proteins. Okay, and we could biochemically show how it does by competing, and again very specific to ABC protein, not other family of proteins. Another molecule, formazole, which is a code sensing molecule, this again competes with the ABC proteins and blocks the efflux pump by competing, almost similar like curcumin, and again specific to this set of protein and not to other set of proteins. So in other words, we have got two kind of leads, you can say. One like peptide mimics, which can be exploited. Second is modulators, which can be also exploited to make inhibitors, which ultimately you like to block the pump, so at least the existing drug itself can be reused to sensitize the cells. And based on these approaches, like I said, we could do this. So far I can say experimentally speaking. We have to do a lot of animal experiments to prove this, that this really happens. And then it's a good news, and we should be able to sort of block the pumps so that we can put much more stuff inside. The same drug can be reused. So with this I'd like to thank you all for the attention.
Excellent talk. I find it topical also, and I also see a little health issue in it. As there's a little reflection of this from my side. As he himself has mentioned, this in Delhi itself we had this one anti-microbial strain of bacteria, which again was found in many water samples and semen samples. And I just related to another phenomenon which was coming up in India, that was of medical tourism. And people, they were coming to India, they are also coming to India, they get their bypass surgery or any other thing treated here at a much lower cost. But again, this thing will happen. Again, dented the reputation of the country as a place for medical tourism. But again, this is not a phenomena which is confined to this India only. This WHO also this year has this message about this indiscriminate and indiscreet and overuse of antibiotics. So again, this is high time that we raise awareness on this issue. And another case in point is that this occurrence of this communicable diseases, infectious diseases, again has risen because of this antibiotic resistance. Take for instance this tuberculosis. Again there is massive resurgence despite the stock treatment in place. So probably there is a need to heighten awareness. And if I can say that we should have some refresher kind of courses for medical people on prescription of this antimicrobial agents. Dr. Prasad, you have any comment from this?
Excellent idea, because indeed we do not have awareness to this problem. In fact, there was a big TV show on this, We the People, and they were all defending why this particular Delhi bacteria named after is named after Delhi and so on and so forth. But they were not arguing that there is a problem exists. It is very appropriate what you said, that the people should be made aware. Doing small workshop, refreshers, even doctors are not aware of this kind of problem. But we encounter almost each day in hospitals. I agree. If I can be of help, I will agree for this. Yes?
It's very high in stem cells or embryonic stem cells, where it makes sense to provide protection at that stage. But in adult stage, what is this relevance in terms of physiology? That's the first thing. The second thing, as I gathered from the slides, that MDR expression is conserved at least in the eukaryotic system. Then why is the kind of mutation does occur and what is this benefit to the host?
The first question, the physiological role of these proteins is still a mystery, but the fact remains that genome has got several dozens of these proteins. Even a plant like Arabidopsis have got more than 100 of these proteins. So we don't know yet, but there is certainly physiological relevance of these proteins. Immediate thing comes out that because of the air pumps, so they are really throwing toxins, maybe secreting something also which is growth promoting or whatever. But these are speculation. What is so far known is that they can flip-flop membrane lipids. Okay, that function is established for some proteins, not for all proteins. That is one. And they are also not very essential. If you knock them out, nothing happens because other proteins takes over. That is the second part was right. This is again a question which we are also studying. What is the evolutionary significance of this degeneracy? Interestingly, it only appears so concentratedly in fungal transporters, not anywhere else. So, what advantage probably it is provided to them become a pathogens or something else, we don't know. But what we can prove with our results, that they are there not for any reason. They are there for particular reasons and they are functionally relevant. You can't go more further, no?
Sir, just want to give an idea about the type of drugs we can use. Like you gave a name of cephalosporin.
Right.
Can you just highlight the which generation cephalosporin we are giving, and why not we can use mRNA-resistant penicillin, MRSA-resistant penicillin, or carbamazepine?
The drugs which you mentioned are already being used. What I would like to emphasize that as you use them, bacteria also learns to become resistant to these drugs. So you always start trying to get a newer generation of chemical molecules. But it is not enough. So we have to struggle to find out new chemicals with new targets. And the trick is do multiple drug therapy. So you give combination of drugs, so bacteria also get confused. So that is how we treat cancer cells. We give multiple cocktail of drugs. So that is one of the steps.
Sir, but that either will be costly or it will have other side effects or they do not have a synergistic effect. So regarding that thing you specifically mentioned about the cephalosporins, why can't we go on monovectams and carbamazepines? Because these are newer ones and they do not, until date, no resistance has been created against them. So but in most cases if you go for cephalosporins, sir, there are few like third generation and fourth generation. Only they do not have resistance. Regarding what I am asking about carbamazepines and monovectams, sir, why can't we use them?
No, what you are saying is totally not correct. Some bacteria which were even resistant to vancomycin. Okay, luckily it is not alarming, but it exists. So what you are saying I cannot argue, but there are also some problems, and not that these drugs are not being tried. They are also tried.
Sir, vancomycin is specifically used for MRSA-resistant penicillin. Sir, the most critical case is MRSA-resistant penicillin. They are the largest category because till date no penicillin or any antibiotic has been made. And we know that penicillin is the biggest discovery in the world of drugs. So when we have...
It was.
Yes sir, I know. So when we have another category, the vancomycin is still yet used for MRSA-resistant penicillin because the MRSA-resistant is the most critical one, we can't handle them. Only one drug, vancomycin. So now you are saying that we have got resistance against vancomycin. Sir, then what is the newer approach to approach the treatment of drugs regarding antibiotics?
Let us find new drugs with new targets. That's what the message I'm like saying. And try to minimize the emergence of resistance by minimally using drugs, avoiding short course, all kind of things, so that the drug resistance emergence is delayed.
So sir, what are the advancements that have been made in the field of cephalosporin, sir? Because you have just now mentioned about cephalosporin. That thing only I am asking, sir. What are the recent advancements, sir?
I don't know. Recent advances, I don't know. What I know is that there are quite a few drugs now with new targets are going to appear in the market.
Thank you, sir.